really is, it's a very creepy place.
Oh God, yeah, that's, anyway. But super excited to have you with us today. I think to start out, would love to just, from your own perspective, your kind of background and story, be like 2 or 3 minutes. Particularly, I think for clinicians that then make the leap from like more traditional clinical paths to like startups. That's like a big decision, and so I'm always really interested in like the narrative arc of how you kind of got to like, I'm gonna go start this company. But kind of maybe going back a bit further, like how'd you get into healthcare? Like, kind of why'd you choose to specialize, why you wanted to, and then kind of how did that arc lead to Cityblock, which also should give people some good perspective on just the lens you bring to all of this.
Cool. Okay, I'll do it. I'll do the quick version.
Yeah.
So I'm a family doc, and very quickly by background, was born in Boston. My parents were immigrants from Nigeria, and I grew up in East Africa. So I spent my entire childhood kind of at the peak of the HIV epidemic in a pretty privileged kind of economic environment, but really seeing kind of the impacts of poverty and lack of access to healthcare and social services and disparities in health outcomes. And that was sort of the like early, I'm one of those like annoying people that was like, I knew from the very beginning I wanted to be a doctor. And I took the scenic route, came to the US for college at 17, went to Stanford, so spent my first sort of 5 years really living in the US on the West Coast. Totally missed the Silicon Valley like vibe. I was like stuck in organic chemistry and physics and like boring stuff like that. And so entrepreneurship was nowhere near on my radar at the time, even though so many of my classmates kind of went on to the Valley to end up in doing sort of entrepreneurship types of activities. And then I worked in San Francisco for doing health and human services, again, with the HIV positive population. Moved to England. I wanted to be closer to my family who's still in Africa, wanted a change of scenery. Found a lot of the sort of social dynamics of the United States as a first time kind of, my first time sort of living there, living as a Black woman in America, found that very complicated to sort of navigate, and actually deliberately chose to go to Europe for a few years. And so I spent 5 years in England, did a master's degree, did medical school there, trained as a doctor in the National Health Service in London, which was amazing and really interesting to see sort of what a socialized healthcare system looks like and feels like. And so had a very different education in terms of access to healthcare, how we allocate resources, how we make clinical decisions about who should get resources. It was entirely based on sort of thinking about, the community pie and how to most rationally and equitably distribute those resources. And so found it no surprise. I did some work international health. So I was in Sierra Leone for a while. I lived in Ethiopia and Tanzania, and sort of did a lot of kind of really trying to figure out how to put the pieces together on broken healthcare systems. But no surprise, it was a real shock to me when I came back to the US for residency to understand just the extent to which kind of socioeconomics, demographics drive health outcomes independently of resources. The pie is huge here, as you know. We spend $1.5 trillion of taxpayer money on healthcare for lower income people, for older people, for people with disabilities, and it is so inequitably distributed that it was just a huge dissonance I couldn't wrap my head around. And so for me, sort of the path to entrepreneurship was really about honestly trying to like create a practice environment in which I could practice in a way that was aligned with my values. And so that started with being a little bit of a rebel rouser and sort of, starting clinical programs that hearkened towards value-based care, but were really focused around, actually meeting people's needs, trying to get them home safely from the hospital, trying to make sure that we solve for not just the prescription that we could write as physicians, but also, can you eat? Do you have enough food to eat to go with that medication? Do you have a warm, safe place to sleep? Are you struggling with education and with literacy? Are there other factors that impact your health outcomes that go beyond the medical, which is how I was trained to think about healthcare and to think about health outcomes, and realizing that there wasn't a really clear path for me as a primary care doc who was really interested in serving families and serving underserved populations to practice holistically, despite sort of all of the promise of community health centers and safety net hospitals. They weren't meeting that charge. First thing I did was step out of traditional academic medicine, and I took a job at a health plan in Massachusetts, Commonwealth Care Alliance, and was really recruited there to help the at-risk insurance plan. So they have financial and quality outcomes risk for people who have disabilities, medical, social, behavioral health needs, achieve better outcomes. And being able to say, hang on a second, like we can actually get to the top of the food chain in terms of resource allocation and choose to redeploy resources in the healthcare system to better invest in primary care and mental health and community-based social services, as long as we're able to see that bet play out in improvements in health outcomes on a population level. And that's where I learned sort of the business of healthcare and the business of publicly funded healthcare, particularly focused on people, my people, people with disabilities, people with mental health challenges, people with low income, the people I wanted to serve. And from there, really starting to see that there was an opportunity, there was a model that worked. And what we were lacking was data, technology, analytics, and capital to really innovate and to scale. When the opportunity came for myself and Aya Ram, my other co-founder, to come to New York and incubate what became Cityblock at Sidewalk Labs, it was sort of like we couldn't pass it up. You know, I'd seen a clinical model that works. I know it is possible with the same resources to get better outcomes and actually to create more resources, to create margin savings by keeping people out of the hospital and keeping them out of, you know, costly exacerbations simply by investing upfront in preventive and community-oriented care. It was sort of like, this is your chance to make this the norm as opposed to the exception. And the way to do that was really to build a sustainable business case for this work. And so to take the clinical model that I'd worked on and really built and align it with economics that allow us to do this at scale and allow us to prove the point that there's a better and different way to do this that achieves outcomes for all of the people we're trying to solve for. So that for me was my path. It was not an intentional path. It was really a seeking to solve for the thing that I want, which I have today, which is I still practice, I still see patients, and I want to go see patients in an environment that allows me to take the time to understand what's going on for them, to help acknowledge and then solve for all of the nuances of the experience that makes us humans, and to see them get better over time. That's really all I wanted, and we had to build a company to do that, really. There you go.
The inane friction from the thing that sounds obvious in U.S. healthcare.
Yeah.
One of the things, I've seen a lot of people come into the South Park Commons community, engineers in particular, and like have a personal experience, see the press in healthcare, and they're like, oh my gosh, there's so many acronyms, there's so many terms. The people that are paying for it are like different than who's actually like, how do I navigate this web? And I think part of that is it's just really complicated. Part of that is there's a lot of jargon. I think one of the terms that gets thrown around a lot that I think people don't always unpack, that I would love your, like, however you define it, like what does value-based care mean to you? And then like, how do you think about, like, if I'm someone who's looking to go join a company that's in healthcare or like thinking of starting something, like how should I be thinking about how I look at something, you know, the broad umbrella of value-based care?
Yeah, absolutely. So, you know, this is one of the few terms in healthcare that actually means what it sounds like it means. So value is, you know, quality over cost, right? Like, can you get like the outcomes you can achieve for every dollar you invest into the system? And what is true and also mind-boggling about our existing healthcare system is that actually the value equation doesn't play into the way that we typically finance healthcare. So typically, healthcare providers, so doctor's office, specialists, your emergency room physician, your outpatient surgery center, they get paid for providing care to you, irrespective of whether or not that makes you better, irrespective of whether or not it was the most efficient way to deliver care. And their incentives are aligned entirely around maximizing billings and maximizing returns to them as providers, as opposed to understanding whether or not every dollar we spend actually improves quality and improves outcomes. And so value-based care for me is the inverse of that. It's actually saying, you know what, we're going to align fully incentives between the people providing care and the folks paying for it, such that we pay for outcomes. We pay for value. We pay more for things that deliver more outcomes, and we pay less. And in fact, we try to reduce both the unit cost, ideally, but certainly the units delivered of things that are not high value. And for us at Cityblock, what that means is that when I see a patient or when one of my clinicians does a home visit, we don't get paid for that individual encounter. We get paid in aggregate across the population if the folks whom we care for are engaged, have better quality scores and do better clinical outcomes. And more important, most equally importantly, they don't get so sick that they have to be hospitalized for things that we could have treated in the community. So, the inverse, the sort of historical and more prevalent way of paying for healthcare says, you know what, if I ignore my sick patient with diabetes, or I provide them with, the typical 10-minute doctor's office visit, microdosed, if you will, over the course of, 6 months, and they end up having a really, really bad infected toe and get amputated, I get paid a hell of a lot of money to get to amputate that toe. I get paid pennies on the dollar to do the primary care visit. And I certainly don't get paid at all to do the home visit, to check to see if they have enough food, to see if they have the right sort of literacy level to understand their medications. There's none of that is actually reimbursed in the healthcare system. The inverse in our model is we get paid to make sure that amputation doesn't happen effectively. We get paid to do everything that's necessary to meet our members where that's what we call the people we serve, meet our members where they're at, advocate for them, provide primary care, mental health, social services, the whole kind of integrated care continuum. And because it costs so much less to do all the things I just described than it does to amputate someone's toe, we actually generate savings in the healthcare system that becomes our margin and gives us the license to scale.
And tactically, does that essentially mean you're just breaking down like almost like, so you're getting capitation payments? So is that correct? And so it's like you're getting $100 to pick a round number a month to say, hey, go care for this person or this bucket of people, and we're going to pay you $100 a month. And because we think that's how much the care should cost based on our actuarial model, and you keep some portion of, like, if you reduce you can deliver that care for yet less. Is that?
This is where it gets a little bit more complicated. Let me
try to like give it a tactical but not too complicated example for the group, so they can like a little bit just understand what the details of how you actually achieve that from a business model standpoint.
Sure. Okay, so I'll do the math for you. Picking round numbers. So these are sort of illustrative only, and I'm terrible at arithmetic, so someone will yell at me if they don't add up.
They don't need to add up.
So let's assume one of our members who has multiple chronic conditions, high needs. So this is not your typical patient. Let's assume that on average their healthcare costs $1,000 a month, and it has done for years and years and years. Now, it's important to note that $1,000 a month is significantly more than their insurer gets paid to care for them. These are the folks who are the sort of tail end outliers, who it's typically about 10% of the population, drives about 60% of the cost. And so it's really like this sort of barbell kind of shaped spend trend for a population of people. So think of a person with complex needs. They've got a ton of unmet needs. So what typically happens in this population is, the healthcare system is really the only place where a person who is hungry, is lonely, is sleeping outside, has unmet mental health or physical health needs, can go and consistently, at least for a minute, be treated like they matter. And so people like this tend to show up in the emergency room all the time. And they're hitting the ER because they didn't get their prescription for their medications they needed. They didn't get the primary care visit that would have helped to identify their diabetes before it got too late. They didn't get the outpatient mental health therapy that would give them the tools to cope through a loss or a setback. And so we see these very high baseline costs of care. What we typically see in this population as well, though, is relatively very low spend in primary care and mental health, because everyone in this population, often they have a PCP, they have a primary care doctor on record. But if you have to take time off work, pay for childcare, pay for transportation, go to a doctor's office, sit and wait in a place that often doesn't make you feel seen. It's not a swanky, the typical sort of clinic that serves Medicaid patients is not a swanky One Medical, customer service environment. It's a place where you feel like you're just a number. And so for them to do all of that it's a high bar. It's a very, very burdensome ask, often, particularly for people with chronic health needs, where they don't typically feel, if I'm hungry and about to get evicted, the fact that my blood sugar is a little high and maybe I feel a little dizzy may not be the most important thing on my day. And so these folks tend to have very low utilization of primary care, very high utilization of emergency services, and almost no real consistent mental health supports and services. And we know, especially through the pandemic, just how important that is for people. So what you typically see is a very small proportion of that $1,000 that it costs to care for this person is actually spent on things that would change their outcomes over time. And the vast majority of the spend is on reactive care. It's when you show up in the emergency room in crisis and we do the thing that's putting the Band-Aid over the sort of the fire hose that's gushing out, and just to get them out the door and move on to the next day. What we do is we get paid up front a lump sum, to your point, maybe it's $100, maybe it's $90. It actually doesn't matter what it is. It's almost a cash flow mechanism more than anything else to invest in primary care, mental health, and social services. And what we know is that in a very well-managed population, ideally, particularly people with chronic and complex needs, ideally you're spending about 10, maybe to up to 12 or 15% of the total medical spend on primary care and mental health and social services. And that is rarely the case when we at Cityblock take on new populations, because they're just so unmet in that space. So we care for them and we deliver services through our field-based team, our omni-channel access points, digitally, in person, in their homes, in our physical hubs, providing an experience that is engaging and that wraps around not just the medical, but also the behavioral and social. And then we reconcile against their overall medical spend. So the health plan, if they do go to the hospital, pays the bill. If they go to the specialist, they pay the bill. For the pharmacy, they pay the bill. And then in a quarterly basis, we look back and say, hey, did that person who used to spend $1,000 of healthcare dollars a month, most of it on reactive care, do they now spend $800? Well, we've created savings here. And that's actually the thing that is the value. It's the value that is created by investing in those services, where we see clinical outcomes get better, we see social outcomes get better, we see engagement be through the roof, and we start to see people not go to the hospital for things that we could prevent and treat in the community. And that's actually where the margin is generated.
Yeah, no, why do you think it's not, like, why is this such a unique thing? Like, why is this not just how it sounds, to your point, sounds so logical when you walk through it? Like, why do you think this is not like a broader, this is just how care is delivered in the US? And like, do you think it'll get there in the next 5 years?
We've certainly seen it. So we didn't invent value-based care, right? Like there are many companies, both in the sort of venture-backed space, as well as in the nonprofit space, really pushing this. The federal government has been increasingly pushing to create alignment between providers and payers. States are increasingly pushing for value-based payment. So it's clearly recognized that one of the main levers for improving health outcomes is to start to create real alignment between the people who deliver care and the outcomes we're seeking to see in the population. But change like this takes time. Like healthcare is a massive industry here, and we've built institutions and edifices to the fee-for-service model, right? Like it is, hospitals in New York City, where I live and practice, compensate neurosurgeons through the roof relative to the way they compensate primary care doctors. That's because if you put a rod and a couple of screws in someone's back for back pain, you get paid way more. And that's a legacy fact. It has to do with lobbying. It has to do with the cost of training. It's so complicated, but we've built institutions around this, institutions that are profitable, right, around this. And what we haven't had until recently is a real counterweight to that. That is, honestly, it's the voice of patients and community members saying, actually, and citizens, taxpayers, these are our dollars we've invested. We wish to see them put to better use. We actually want to see value out of this. And so we're increasingly seeing a ton of tailwinds in the policy space and in the healthcare space as a whole, moving towards value-based care. But to do so, and to do so well, like this is, disruption is like a very oft used word in the VC space, but this is like real disruption. Like there will be, we will have to dismantle and reassemble our healthcare system. We have to redefine what we value. We have to pay differently for things. We have to train people differently. We have to take away from folks who have been doing very well in healthcare, but perhaps not delivering commensurate value, and invest that elsewhere. And that type of disruption on the scale of which we need to see it in this country takes time. And it will hurt people's feelings and it will hurt their pockets. And so, it's a process for sure.
Yeah. And so, you're getting set up with Cityblock. Business model is like, set up and operating kind of upfront. This is what we're going to kind of be roughly jumping into. Then you're coming from Commonwealth Care Alliance, and then at Sidewalk, at Cityblock, you're working with like world-class engineers, designers, product folks on how do we build this experience. One of the things I think is most challenging in these startups is like the culture of clinical care delivery and the culture of product design and engineering are very different cultures. And so I guess both for you and then broadly for the company from those early days through today, how have you like understood and built understanding and how to get those very different groups of people from around to work together as like one team?
It's such a great question. And it's been, it's been a real learning journey for me. It's been one of, I mean, there's so many things, as you know, that are like deeply humbling about building a business. For me, this is one of the most humbling things. Like I've had to learn so much. And so I will own these lessons. And I think that they may be lessons for others. So, like many physicians, my experience of technology prior to entering the startup space, and I told you, I had my eyes closed to Silicon Valley when I lived out there. So I literally knew nothing. And my experience of technology was as a victim of it, honestly. Like I'd been through probably at that point 5 different electronic health record implementations. EHRs get a really bad rep because they're terrible. They're not designed with the users in mind. They're not designed to facilitate workflows. They're designed to bill and submit claims for like units of services we provide to people that do not consider a human as a whole person, and certainly don't consider the way that we as clinicians were trained, right? So that was my entire experience. And yet I was really excited about working with technologists because I believe and continue to believed then and continue to believe now that technology is actually going to be the key to unlocking our ability to scale. And we started Cityblock. We collectively were uninterested, honestly, in being successful by sort of venture standards, right? Like that was not what we were looking for. It was very clear to us that you could build a big and successful business in terms of multiples, in terms of exits in healthcare, and not actually move the needle for the way that health is experienced and healthcare is experienced in this country. So that was not interesting. We set our sights on like big scale. Like we set our sights on saying, we wanted the care that we deliver to be the norm as opposed to the exception for poor and marginalized people in this country, which means we have to actually go after the TAM, like go after the tens of millions of people who are getting terrible substandard care today and who are likely to experience a 10, 15, 20-year life expectancy gap based entirely on their income, entirely on their race, entirely on their comorbidities. That's totally unacceptable. And that meant for us that we had to figure out how to scale. And that means scale processes, scale people, scale tools, and most importantly, scale the next best action for people. When we start to consider decision support as much broader than like what was the most recent randomized control trial for the measurement of blood pressure in this carefully selected population that looks nothing like the people I care for which we've controlled every single human externality, like that's not interesting to us. But the question of like, if I've got a guy I'm caring for who struggles with schizophrenia and is an occasional cocaine user and sleeps on a park bench and has lifelong trauma, what's the next best thing I should do for him? That is the problem we need to solve. And that's where data becomes really powerful in healthcare. And so I was like super pumped about getting to work with technologists to unlock this huge ambition we had. But I didn't know how to work with them. I expected IT to do the thing. I was like, IT, they will do the thing I asked them to do, right? Like, I'm just going to tell them what to build, we'll build it. And, but I also had this sort of very clear sense in my back of my head that like, if it was as simple as saying, take a doctor, any doctor, right, and like build the thing they actually want, we would have solved this problem a long time ago. The problem is not that we don't have the tools to execute our vision. The problem is we haven't actually approached healthcare and solving these problems with a true design-oriented, research-oriented, empathetic approach to building technology. It has to be iterative. It has to be hypothesis-driven. It's art, it's not science. And I think, interestingly, as a clinician who thinks about clinical care as art and not science, I thought that technologists were scientists and not artists, right? And so really realizing that actually we had to find language and space to co-build, which meant we had to create opportunities to listen to our end users. The other thing that's interesting and I think really important about what we build is unlike many health tech startups, we're building for users who are typically not like the people who are building the solutions. And so you see a lot of products out there that are built for people like us, quote unquote, where it's, and that works, it's fine. But when you're solving for the needs of a population who typically don't have a seat at the table, you have to go talk to them. And you have to iteratively ask them what they need. And you have to build teams, particularly the technology teams, that are deeply empathetic and rigorous and iterative in their approach. And we think about, honestly, the clinical guidelines and processes and tools as guardrails, and as well as and not as like the sort of tracks that we ask people to build along. And that shift in power dynamic and in emphasis and in focus was a really important one we made probably about 18 months into the business, when we realized that actually we were under leveraging the power of technology because we were building the thing we thought we needed, as opposed to saying, you know what, we're going to give our technologists context and space and tools and problems to solve, and let them solve the problems, as opposed to telling them what we'd like them to build. And so it was a really profound shift for me, and has been really just pretty joyful and such an interesting set of learnings as I get to understand more and more what building technology looks like and feels like when it's done well, and how it can be so complementary to the clinical expertise we bring, in recognizing that we're solving a problem that neither of us can solve alone. Because the flip is also true. I see a lot of technologists out there being like, these healthcare guys are so dumb. Healthcare is so broken. Why haven't they fixed it already? We'll just go build a business. And it's like, you need both. There has to be real synergy there. But there has to be real collaboration in a way that I hadn't seen before, and I think we're starting to build out.
Yeah. What were some of the specific moments for you, like early products, early data analyses, early like engagement with members, where you're like, whoa, like this is giving us data or tools or enabling us to create an experience that like you couldn't have created before without kind of the full stack approach working alongside, clinical engineering, design, product, et cetera. Whether there's a one aha moment, or like was it like a year where it was just like, wow, like this is all kind of coming together?
It's been more iterative than anything else. I think, I think one of the attributes of at least my flavor of entrepreneurship, I guess, is you have to be deeply I'm impossible to satisfy. Like intrinsically self-critical and intrinsically sort of pushing and pushing and pushing. And so the aha moments for me, honestly, are when someone else, and typically when we bring on a new team of clinicians, and you'll see it like light up in the Slack channel. They'll be like, oh my gosh, this thing is the thing I always knew I needed and I didn't know I needed. It's like, I can see here everything that's happening with this person whom I'm caring for. I can see their social needs and their capabilities alongside their physical needs, alongside their behavioral health needs, alongside all of the components that make us human. And I can communicate with a team to get work done on their behalf. And I can see what matters to them all in one place, right? And like, now I take that for granted because that's the thing we intended to build. And that's what our platform Commons does. But I'm reminded when I see other people's reaction to it, that we've gotten the real like primitives in place that allow us to really focus on technology enabling humans to care for humans in a more effective way, as opposed to technology sort of sitting front and center and in many ways disrupting that human relationship and that ability to drive forward on behalf of the people we care for. Those are the moments for me, I think that are most just reflective of kind of the path we've come so far. And I don't think we could have done one without the other. There's no way we'd get there with one input absent the other.
Yeah, and so for you, it's the power is unified data view and collaboration that essentially empowers. I mean, if you go look through Cityblock's jobs page, it's like the range, like it's paramedics, it's community health, like the range of people that you are coordinating is incredible, like even broader than what you'd see in a lot of other healthcare startups. And then to your point, it's the population that you probably can't make the same assumptions around, familiarity with technology or understanding kind of how to navigate parts of the healthcare system. Are those like the two biggest levers you've seen around unified view, collaboration, or three, I guess, engagement? Or like, how would you say like,
yeah,
the
so there's four core kind of prongs. So it's the unified view, absolutely. Engagement and our ability to do the thing that has been really, really elusive. I wager partly because people haven't tried that hard, but is to engage lower income populations without tons of data on their phones, without, we have actually very high smartphone penetration, but access to data is a big challenge for people. Technology savviness is a big challenge for people. And we've been able to crack engagement, digital engagement in this population. So that's key. And building not just this is again where it's not just tech, it's also human services, right? Like it's people plus tech, getting our members onboarded onto technology so that we can engage with them asynchronously and synchronously much more efficiently, and honestly improve access to services by using technology. The third for us is around decision support. And this is where I think the data play becomes really, really powerful. No one's really thinking about generating next best action analytics for this population. We've got these pure, research studies that think about people as though they don't have multiple comorbid conditions at once. We think about people as though they are not a product of their society or their culture or their social networks. And so this is like, let's take into account this massive, massive heterogeneous set of data, and use that to understand when and where we should be intervening with whom. And then the final piece, of course, is this teamwork and collaboration. To your point, such a heterogeneous set of stakeholders. Most electronic health records even struggle to permission non-clinicians. So if I'm working with a social worker, I'm working with a peer recovery coach, if I'm working with a community health partner and outreach specialist, they don't exist to the EHR. And so we had to build tools that really recognize that our people are seeing social workers, they're seeing outreach workers, they're going to food pantries, they're touching the health and social services system and people within that system across a very heterogeneous skill set and background set multiple times a week. And we've got to build technology to actually understand and reflect that and to enable those people to coordinate.
Yeah, it's incredibly powerful. And decision support is, do you want to define that just for the group, if people don't know exactly what that is?
Yeah, absolutely. So, so when you think about, the critical thinking and decision making that happens in a clinical encounter, healthcare's been really, really bad at democratizing information. So there's this sort of classic, I don't know how they measure this, so, but there's this sort of classic, oft-cited truism that it takes 15 years for a new clinical practice to become ubiquitous, right? So someone publishes a study in some sort of obscure journal, it's behind a paywall or something, and it takes 15 years before the findings become clinical best practice that every clinician uses, because it's a one-to-one. You go to continuing medical education training, perhaps you have a friend who's up to date on the most recent literature, and then you just like in the room with the patient, there are very few kind of checks and controls, and we've not established really robust ways of pushing people to do the recommended action. When you then broaden the aperture and say that's for like when we have clinical data, that's when we did a randomized control trial. We're not even doing studies of that nature with that level of robustness and integrity, thinking about how to intervene socially, thinking about behavioral health best practices, thinking about how you stack up when you've got somebody who's got 5 chronic conditions and not just one, which takes precedence over the other. What are the actions that you have to unlock? For example, we now know that if you have a person who struggles with substance use and addiction, who is also seriously mentally ill, who's also homeless, housing them first is the most important thing that you can do to then unlock their ability to get sober and to stay healthy and out of the hospital. We know that through a number of small studies focused on this specific segment of the population. But think about all of the other permutations of that question that we haven't even begun to crack the code on, in terms of, is it most important to start with treating trauma for someone who's struggling with medication adherence? They don't take their insulin because they're traumatized, lonely, and the cognitive burden of their poverty is so great that at the end of the day, they can't remember to take their medication. Which do I treat first? Get them into behavioral health therapy first, and then their medication becomes easier to manage. That type of decision support, that best practice gestalt, conveyed to a multidisciplinary team so that everybody knows what their role can and should be at what stage? There's a temporal nature to it, which makes the data question so interesting. There's also temporality, right? At what stage is the most important thing we can unlock, because then what you can do is you can scale, as opposed to today when most integrated clinical models like ours even that use interdisciplinary teams focus very heavily on what we call case conferences, which is basically like a big organized phone a friend. Like everybody gets together in a room, you talk about the patient, share the information, and people like brainstorm best ideas, and then the team picks the best idea and they go forward. That's literally how we make collective decisions for people with complex needs in healthcare. We do it in oncology, we do it in complex care management, we do it in, you name it. And that is like so inefficient and so not scalable. And so when you think about the number of parameters we're dealing with, we've got to be able to automate this. And when you have, as we have now, so many individual points of data, I should be able to query our experiences and say, hey, I've got this person, Toyin, in front of me. She's got these 5 problems that she's struggling with. She grew up in this community in this time frame. She's told me that she experienced these types of experiences in her childhood, and she has 3 children. What I know from taking care of 15,000 Toyins is that the most important thing for her is X. It's really likely that she's struggling with depression. She's never told anyone about it. So we should really try to get her in front of a therapist, but she might resist it. So let's think about these ways to do it first. Like that level of specificity around decision support is what we have to have. And we believe we have the infrastructure to start to generate those next best action sort of decision support tools, and then to surface them within our platform so people know what to do next. Like a GPS, not like a sort of autonomous car. We're not telling people how to practice, but we're giving suggestions that are born in the evidence, that are specific to the types of people we care for, that allow people to shortcut this like trial and error process that just burns cycles, burns trust and patience and engagement, and doesn't always yield the outcome that we're looking for over time.
Yeah, it's like a really interesting intersection of kind of classic consumer product, consumer engagement, almost like growth marketing thinking with data science, with clinical research, and how do you kind of meld those together and shorten that cycle time. That's one last question, and we'll do questions from the group. I find that when building one of these really complicated companies where you're doing tons of things, you start to encounter all these other products that are terrible that you wish something would exist, that you're like hacking together a half solution for, and you're like, God, if someone would just build X, like we would use it tomorrow. Like, are there any companies or ideas that you just wished existed that would make, you know, Cityblock's life easier in scaling?
Yeah, such a great question. You know, it's not an exciting answer at all, because it's like there's so many, when you think about we've built our healthcare system around a set of things that we value and prioritize, and they've typically been revenue in a fee-for-service environment. All of the infrastructure required to enable population health doesn't really exist. The views on the data, the logic that links a person like Tom Smith in the healthcare system versus Thomas Smith who goes to the food pantry, whose address is different. Like all of the sort of like guts of what it looks like to link data, to link information, to render that interoperably through different sources. I wish that existed. And even something as simple as saying, you know, if a person hits 3 or 4 different types of healthcare providers, can I see their records in a really synchronous way, in a way that is that pulls all of the fields into structured data, because I know it exists, so I don't have to repeat the labs that were done at the urgent care 2 weeks ago. Like that infrastructure doesn't exist. You have to cobble it together. Increasingly, we're seeing some companies start to build in that space, but there is a real fundamental infrastructure around caring for people longitudinally and having singular points of accountability for their outcomes that doesn't exist today, because honestly, no one has been incentivized to build it.
Yeah, you have to build everything. So if people want to build something, should they reach out to you and start building? Like, do you work with startups? Do you have like a program where you're like, come EIR for us? Or how do you think about?
We're just starting to contemplate that. I mean, I think I got some early feedback that was like, you know, 2 startups working together is like, it's like the blind leading the blind. You should try to avoid it at all costs. And, you know, honestly, there's some truth to that, but there's a lot of truth to the notion that there's real opportunities. We don't need to own every element of our stack. As you can imagine, that would be impossible. And so we are hungry for partners. And we're really at this point have now built the infrastructure that would really enable us to constructively partner, even in co-building situations around the types of services, tools, systems, and infrastructure that we need for the business. And so, a year ago, I might have been like, I don't know. Now I'm like, bring it on. Like, I want to talk to people who are interested in building things, who are interested in creative structures around that build. If you want to retain some autonomy, but also want to have a partner to build with and for, we're having all those conversations all the time.
Yeah. Amazing. Yeah, it's an incredibly exciting time to build for the upstarts. Some questions around the upfront negotiations. So that upfront contract that was the like, hey, it's $1,000 and we get this upfront. Like, how did that negotiation go? And like, what was like, how do you think about structuring that?
Yeah,
and like
I think
power balance there.
Yeah, I think we were certainly fortunate. So, myself, our other co-founder, Aya, we both come from healthcare. I had held the seat of many of the people I was negotiating with in those early stages. I was the chief medical officer of a health plan. I know the reports they're looking at. I know the data they're looking at. I know what metrics they're trying to solve for. And I know the people that they're struggling to care for. And so the negotiation really came to a much more kind of collaborative starting point, because what we're saying to them is, hey, I know you're doing a really, really great job working as hard as you possibly can with the tools you have. I know these people, and I know I can promise you, and they would be like, oh, they sort of looked at their data, and we were right? Like, I can promise you that you've reached less than 10% of the highest risk patients on your monthly roster, the people who are consistently in and out of acute care, the people who have unmet clinical needs, the people who you're struggling with the tools you have to engage. I know that. And it's not your fault. I think there's a different and better way. And this is how we have built our clinical model. This is what we're bringing to the market. And so there was a real initial kind of like, I see you moment, and then also an excitement about what we were delivering. Working with an early stage startup, these companies know, these insurers know, it does not behoove them to shortchange us, because then they've got patients, they've got members who are not getting the care they need, right? So we're starting, and I think that's one of the things I love so much about healthcare is, people don't go work in healthcare because they want to hurt people. They go to work in healthcare because they want to see people get better. And there's a real, like, if you can start with the foundations, I often start, partnership conversations. We start our team meetings with a patient story. Like, really, these are human beings that you hold accountability for, that despite your best efforts, you're probably not serving as well as you could. And here we are, willing to not only take on the clinical care for these people, but we're going to take on the financial risk for caring for these people. It behooves us to figure out a place where we are fully aligned so that we benefit and you benefit, and we can continue to grow and scale together. And that is the foundation for that type of a negotiation. This is not a vendor relationship where you're trying to like beat them down to the lowest cost, because people will suffer. We won't take the deal. And so you're still kind of in the problem where you don't have, you don't have a solution for your population. But most importantly, we want the same things, is we want people to get better, and we want to have the resources to continue to reinvest in growing and scaling together.
And as you've been doing that, you mentioned earlier, there's parts of this type of model where a lot of people are going to do a lot better, but a lot of people are going to do worse economically. Have you seen specific other players in the system be incredibly excited or resistant, or like sometimes like try and slow down your progress, or like what's the general reaction to the from the community been?
Yeah, I think the benefit of being small in the early stages is that nobody really notices you, right? And so we're small, we're in the Medicaid space. And those are two things about us that that tend to allow us to fly under the radar a little bit, right? Like most of, despite what they will say to you, many of the big sort of powerful health systems would much rather have their hospital beds filled with commercially paying patients for whom they can bill much higher, and for whom they don't have to worry about the complexity of their post-discharge follow-up needs and their mental health needs and all of the other challenges. And so there is a tacit understanding that that Cityblock's existence doesn't threaten the sort of the existing economic drivers of many of the big people, particularly the folks who have power in a community, as for the provider system. And so that's just, it just is what it is, right? Like they're acting in their own best interests, and in in reflection of the system that we've created around them. And so no shade there, although it sounds a little shady as I say it. But there's that piece. I think as we get bigger, and truly, like, I think success for me will be when health systems feel threatened by us, when they have to behave differently, when they're asking themselves, goodness gracious, should I open another high-end interventional robotics suite, or should I pay for housing? And turn that extra bed into like affordable housing for people. I want like that's success for us. And so like, bring it on. Like, I don't actually care. I think we need to poke the bear. We need to say the thing, the uncomfortable thing, which is that we need to reallocate resources significantly in our healthcare system. And that means that some people will feel worse off for it. And that's probably okay.
Yeah, the dichotomy of commercial being employer-sponsored insurance largely, or some degree of individual market for if that's not a term people have heard.
Sorry, yes.
Which pays, no, it's fine. It pays at a much higher rate than Medicaid or Medicare does to one health systems. So
you could do, as an example, the same procedure for a person, and depending on their insurance, the reimbursement could be, an order of magnitude different. And in many, it depends very much on the individual negotiation of those contracts. But for many of the sort of like top class brand name hospitals and health systems, that is the case. And so they're more incentivized to want to do a procedure or to hospitalize a person who has that type of insurance, the type of insurance that most of us in this room probably have, versus the type of insurance that my patients have, which is tends to reimburse at a lower rate.
Another question on the data. So like, for care guidelines and broadly, like these care suggestions are like these big existing industry providers, like minimum care guidelines. And then there's the things you're generating, which are kind of like novel or unique. How have you thought about like, does how you scale that? And Douglas, let me know if I'm missing the core of the question. I think about like scaling that and like how specific it is. Is it down to like an individual? Is it down to just a zip code? Like, how do you think of the different areas you can slice that, and how you think about when you open a new geo, can you follow those same patterns in another geo? Like, what's actually localized versus what's generalizably true?
It's a great question. I don't know the answer yet, is the true answer. For some of these things, they're pretty generalizable, because we're starting from a relatively low bar today in terms of the amount of data that actually informs, and the ways in which data informs clinical practice and social care delivery today. So as an example, I have found it in my sort of clinical experience, entirely from heuristics and Gestalt, to be true that when I see a patient, I can just tell from their data. When I see somebody who goes to the emergency room frequently, so typically more than twice a month, and they don't have any chronic, like real significant chronic conditions. So they don't have diabetes, they don't have high blood pressure or heart failure, they don't have kidney disease, and they tend to not get admitted to the hospital. They go to the emergency room, they get treated for a few hours typically, and they get discharged home. I will bet like my house that person has a serious mental illness and or significant trauma in their background, and that they're probably struggling with a social gap. Because as I said earlier, the only place you can consistently go and get cared for and treated like you matter, if you are hungry, if you're lonely, if you have no place to sleep, if you feel unwell, is the hospital, right? And so that's the kind of clinical pattern you see, and you see it played out in the data. Is that translatable and extrapolatable from North Carolina to Washington, D.C. to Massachusetts, and it's actionable? And the answer is yes. And so we can bear that out in the data, and we can surface to the care teams, this person needs more than anything a significant understanding of their social milieu. Do they have a place to sleep at night? Are they hungry more often than they're not? And have they experienced early childhood or repetitive trauma that we can intervene around with behavioral health services? That works, it's 100% true across the population, I can guarantee you. What those services look like in North Carolina or Washington, D.C., it's going to be different. What the nature of their downstream needs, that's going to look different too. How we intervene in this population versus another will also differ. But there is some foundational, we're looking for these like scalable components that we can then build on top of, where that nexus between what is generalizable and what is local becomes much more apparent. But we have to raise the floor here in terms of our understanding of humans and what drives their health outcomes before we can even build on top of that.
Yeah, it's the lack of unified data and then the actual real insights that bridge that gap is absolutely insane. From Noah, how do you think about like truly going full stack versus like modern EMRs? Like, do you think that there'll be in 10 years like some epic replacement, or do you think, kind of future is verticalized? You have a verticalized Cityblock, you have a verticalized, by all these different clinical areas, like all these different kind of Cityblocks across clinical areas and primary care. No, let me know if I'm asking that correctly.
So I'm not sure I fully understand that. I've seen Noah's written question on Jonathan Bush's EMR. I'm not sure I understand the other question.
Oh, so
sorry, I was typing another question and tried to enter a new line, and I jumped the gun. So disregard the last two messages. I'm very embarrassed. But the first question is related to, yes, Jonathan Bush has this new startup, and there's a lot of people complaining about EMRs and all kinds of innovative new providers cropping up that feel the pain of having to go full stack. And it's really interesting, I think, like if they all need to build that infrastructure, or like how much of it is shared and how much of it should we be thinking about maybe building as a pure tech product to sell, kind of taking the general pieces.
Yeah, no, I'm very excited about the notion of disaggregating and modularizing the core components that underpin a high functioning practice. I don't believe it's sustainable. I have no desire to maintain all of this infrastructure that's not differentiated at all, right? And as we have increasing adoption of FHIR and other standards, right, that you can build on top of and that are really, really facilitating interoperability, I think that there's a real opportunity here. So excited to see there's a couple of folks really taking a real hard swing at this. And we are in the realm of your prior question, Tim, about like, how do we think about partnering, collaborating with even early stage ventures like this? I'm all for it. And I think it's definitely the way forward. Is it going to be enough to disrupt the Epics and Cerners of the world? Like, I don't know. They're like deeply entrenched. These are for the non-healthcare people. These are sort of, the leading electronic health records in the market that have both technically and contractually, I think, really locked in a massive, massive chunk of the healthcare providers in this country. And so that's a whole other thing. Do I want somebody to take them on? Absolutely. Will I be standing outside cheering and taking advantage of the innovation that ensues? Absolutely. And so I think we're seeing the beginnings of something really shifting here.
What would be the ones you'd want someone to build? If you were like rank order the ones you see, or if that's a too detailed a question, you can pass.
I would like to play the field a little bit if I can, and so I'm sort of I'd rather not be locked in. I think there's room for a lot of winners here, and we're really excited to build the things that we do believe are true differentiated capabilities and to partner around everything else.
Yeah, I think one of the most exciting things right now I've seen in healthcare from when I started my first company in space a decade ago is there's now enough Cityblocks of the world that are at some degree of scale that you can, as a now startup, build infrastructure for the upstarts instead of having to build infrastructure for the legacy people. And so I think that's a really interesting switch that's only happened in the next few years, is that there's enough of those that you can build something that can actually have the startups be customers. I think all of the Stripe for healthcare. I think we are actually now entering a moment where those types of builds are starting to be possible versus like 5 years ago when a lot of them just died.
Yeah.
Any last?
I do have a second question, but I don't want to take the rest of the time.
We got 1 minute, so ask if you. So you're gonna answer in a minute. Yeah.
Okay, two bold propositions for how to disrupt healthcare. So I was at Forward previously, and they have strong opinions about where healthcare needs to go, and takes kind of the Tesla approach of like start with the high end, and then with technology you can drive down the cost. And then Cityblock takes honestly a very inspiring approach of like go to the people who need it most and also use technology to kind of make it scalable and more effective. Curious to hear your take on that approach, pros and cons. If you think that Cityblock obviously is kind of the most promising avenue, but
with all respect, I think we have no prior precedent for the build it for the 1%ers and then it'll trickle down and impact everyone else. Like there's no, I've not seen that happen anywhere in healthcare. I think the needs of the population we're serving deserve intentional, focused build for those people. I think it's very hard to pivot. I think it's very hard to generalize when you're building for such a different population segment, and when you don't have to, frankly, take into account the complexities of what it looks like and feels like to live in poverty when you think about health outcomes as well. So I'm no surprise, firmly in the camp that if you really believe that your mission is oriented around changing health outcomes for the poor, the marginalized, for the population that does not have access to privilege and to education and all the other sort of services and resources we take for granted, you actually have to build for them. And that means focusing entirely on them. And guess what? The market is huge. It exists. The resources exist. We've now started to prove that you can attract capital specifically for this population. Why would you not do that and focus in on solving these problems? And then great, if we can generalize up, I'd be very happy to do that over time one day. But I think we've got our work cut out for us, really trying to care for and change the outcomes for the people who get left behind in modern sort of innovation. So that's where I'm 100% focused. And I think that's going to be the most likely path to get to success.
And thank you so much for the time today. If people want to get in touch with you to build with Cityblock or interested in working at Cityblock or any of those, what's the best way to do that?
Just dropped my email. It's Toyin@Cityblock. Send me a note. And thank you for the questions and the conversation. It's been really, really nice to be with you.
Yeah. Thank you again. Have a great day,
Thank
everyone.
you. Appreciate it.
Guys, thanks, Tim.